Good morning, my name is Steve Shepherd. I'm one of the intensive care and anaesthetic consultants here at Barts Health and also one of the ECMO specialists here at St Bartholomew's. I'm going to talk to you today about how to prepare, insert and connect a PA catheter. This video concerns the indications, preparation, insertion and connection of a pulmonary artery catheter, which is used in the context of cardiac shock, such as here at Barts, or the major trauma service at Royal London. What is it? So a PA catheter is a multi-lumen balloon tip catheter, which is most commonly used as a measure of cardiac output in cardiothoracic. The tip of the catheter is floated through the right heart into the pulmonary artery. Temperature and pressure measurements at this location facilitate advanced hemodynamic assessment, in particular actual measured cardiac output. A pulmonary artery catheter may also be considered when less invasive monitoring is inadequate for hemodynamic assessment. In major trauma, this might be, for example, where you have an unstable patient with arrhythmias, where pulse contour analysis is ineffective, or there is existing cardiac failure. So what are the intended benefits versus other forms of hemodynamic monitoring? So many other forms of hemodynamic monitoring use assumptions about hemodynamic status or rhythm in order to work. Pulmonary artery catheters give gold standard real-time cardiac output monitoring alongside other hemodynamic parameters. This helps the clinician better understand why a patient is in shock and adjust the treatment as needed. If a patient has profound cardiac shock that is refractory to conventional resuscitation or medical therapy, they may be considered for mechanical circulatory support like ECMO. The data from a pulmonary artery catheter helps support this clinical decision, as well as optimising ECMO therapy once it's established. So there are 4 stages to successful insertion monitoring. Firstly, you need to set an adequately sized introducer sheath into an appropriate vessel. Secondly, you need to prepare the monitor, transducers, cables and catheter. Third, you need to pass the pulmonary artery catheter through the sheath into the superior vena cava. And then you need to float the pulmonary artery catheter through the tricuspid and pulmonic valves into the main pulmonary artery. We'll go through each of these stages now. So what equipment will you need? Firstly, equipment to place a central venous catheter. An appropriate introducer sheath with a minimum size of 8.5 French, such as a trauma line or Edwards Intraflex. A primed transducer kit connected to a monitor, such as a GE or Mindray ICU monitor. A Edwards hemisphere thermodilution monitor with the appropriate connections for a pulmonary artery catheter. An Edwards 7.5 French Swan-Ganz continuous cardiac output PA catheter. The first step is to prepare the catheter insertion sheath for insertion. Ensure sterility is maintained throughout because this line may remain for several days. This will involve priming the lumens and inserting the combined dilator. Please note the sheath comes with a specific plastic cover which is designed to protect the pulmonary artery catheter after insertion. This should be retained. The next step is to prepare and drape the patient, ensuring an adequately sized sterile field. Next, use a Seldinger technique to insert a sheath into the internal jugular vein. Next, maintaining sterility of the operator, open and prepare the Swan-Ganz catheter. This will involve attaching 3-way taps to the yellow and blue lumens, flushing these with saline to confirm patency, and then connecting the 1.5 ml syringe included within the set to the red balloon port. This should be inflated to test the balloon integrity. Next, insert the catheter through the protective sheath which is included with the introducer sheath, and prepare it so that it will be easy to cover. This involves ensuring that the lock connector is correctly orientated so that it will be able to be placed appropriately on the end of the introducer sheath. Next, lay the catheter out on the patient, ensuring that you maintain the natural curve. Think about the orientation of the J tip, ensuring that you would like it to pass through the tricuspid valve. For that to happen from the right internal jugular, the J tip needs to be inserted into the introducer sheath, pointing towards the patient's left. Identify the markings on the catheter which demonstrate depth of insertion. A thin black line identifies a 10 centimeter marking. A thick black line identifies 50 centimeters. You should also identify the thermistor on the catheter, which is where the temperature is measured. Insert the catheter into the top of the introducer sheath until you advance beyond the metal plate. Connect the protective sheath onto the top of the catheter so that you can handle the rest of the device sterilely. Open this out to be able to see the markings. Ask an assistant to help you to connect the primed pressure transducer to the yellow lumen, such that you remain sterile. Open the three-way tap if it is locked, so that the pressure will be able to be transduced, and ensure you can see the monitor. Inflate the balloon with 1.5 ml of air and use the lock mechanism to ensure that the balloon remains inflated. If you have any resistance at this point, it is usually that the catheter has not exited the end of the sheath, and therefore deflate the balloon, advance around 5 centimeters and reattempt. Confirm a zero trace of the PA catheter monitor, and then that the scale is appropriately set for the size of the expected waveform. Typically this will be 0 to 60 millimeters of mercury. Firstly, check that you have a right atrial or central venous pressure trace. This confirms that you are in the SVC. Next, advance the catheter in confident movements, 2.5 to 5 centimeters at a time, watching the trace on the monitor. The first change that you should expect is that the catheter will cross the tricuspid valve and you should get a right ventricular waveform. If this doesn't happen, it's usually that the catheter has entered the IVC. Never advance a PA catheter beyond 60 centimeters. If you find that you have not found the ventricle at this point, withdraw the catheter with the balloon deflated and reattempt. Ensure that you maintain the curve of the catheter, expecting that the tip will cross the tricuspid valve as you advance. For ventilated patients, try and advance the catheter during expiration. If you find you are unable to do this, then you can sit the patient up by about 30 degrees rather than have them flat, and this will help guide the balloon through the right heart. You should expect normally to find the right ventricle via the tricuspid at around 30 to 40 centimetres. Once you have identified this waveform, continue to advance the PA catheter and you see a step up in the diastole pressure of this waveform, such to suggest that you have crossed the pulmonic valve. Again, you should expect to find this at around 40 to 50 centimetres. Continue to progress the catheter in the same way until the waveform becomes damp and the trace stops being pulsatile. This is the pulmonary artery occlusion pressure. At this point, deflate the balloon and withdraw by 2 centimetres. This is vital to avoid lung ischemia or pulmonary hemorrhage. Please note, it is not always possible to obtain this. If you have not obtained it at 60 centimetres, please stop advancing and leave the balloon deflated, as you risk coiling the catheter in the ventricle. Secure the catheter and apply an adhesive dressing. Next, lock the catheter in position by using the torque mechanism at both the end of the sheath and on the proximal end of the introducer. Connect the catheter to the Edwards cables. There are 3 of these, one to provide power, one to provide temperature sensation, and one to provide continuous venous oximetry. Dispose of the relevant sharps and equipment. Once you've entered all of the patient's demographics, you're ready to start cardiac output monitoring. You'll see that having gone through the options and the invasive menu option, you will see cardiac output, cardiac index, and mixed venous oxygen saturation all available as indices for you to measure. Further indices can be added from the settings menu. To start collecting continuous cardiac output monitor data, press the start button. You will see a countdown timer begins. This usually takes around a minute to calibrate, but may take significantly longer or significantly less time dependent upon the patient's hemodynamics. Patients may also require a prolonged time where there are unstable rhythm issues, or if the catheter signal is damped, for example, if it's partially wedged. If this happens, please ensure that you have sight of the catheter waveform, as you should at all times, in order to ensure that you are in the correct place. To connect and collect continuous venous oximetry data, what you will need to do is perform a blood draw from the distal end of the catheter lying in the pulmonary artery. You should therefore take a blood gas from the yellow lumen, so take 10 mils of waste blood and then a small sample using a blood gas syringe, which should be processed using a standard analyzer. Once you have this information, you'll be able to go to this button here and perform in vitro calibration. Press this again, identify the details available from the blood gas, perform calibration. This again will usually take less than a minute, but can take slightly longer where the signal is unstable or there are rhythm or temperature fluctuations. Once this is done, it will ask you to enter the value for the venous oxygen saturation. Press start. Wait for the catheter to update. Again, this may be 20 or 30 seconds, and then you will be provided with the option to enter this data.